Okay, Assalamu alaikum everyone. Hope you guys are doing well. Hope you guys are having a great Friday so far. My name is Abdelrafour Houdane. I am back now for round 2 on cardiac cycles and PV loops. I don't know if any of you guys were here, I think in pre-med, when I taught this topic before. And if you did, you remember just how much I hate this topic from the bottom of my heart, pun intended. It is one of those topics which does seem very daunting at first. I personally skipped that topic throughout like medical school because I hated it so much. But then I realized afterwards that it's really not that bad. It's very simple. It's very logical. It's a matter of like understanding it properly the first time around. But inshallah, today the idea is to kind of go through a bunch of things that we have covered before, and it's like a combination of various stuff that you've taken before and stuff that are new. But together, inshallah, we should kind of understand cardiac cycles, pressure volume loops, how they change in different pathologies, blah blah blah, etc. Again, always nice to start with a very nice, simple introduction just to get the ball rolling. Again, the cardiovascular system effectively is just a pump and a bunch of pipes. It is really simple at being that. And I did this before in pre-med. I introduced like 3 or 4 golden rules just to kind of keep us grounded as we go through the material. Golden rule number 1 is that pressure always flows from high to low. This is a concept in physics, and it's true regardless of you're looking at a plumbing system in a company or within the human body. So let's say, for example, I have this very simplified schematic of the heart, right? You have the right atrium, you have the left atrium, you have the right ventricle and the left ventricle. Let's say I want to pump blood from the right atrium to the right ventricle.
Bro, I'm so tired this week. Bro, I'm so fucking like.
Okay.
Sorry about that. Continue.
No, it's fine. Anyway, let's say I want to pump blood from the right atrium to the right ventricle, right? I have to follow the laws of physics, okay? Some Oppenheimer type stuff. So if I want to pump blood from the right atrium, okay, am I on? Was I muted?
Could you unmute yourself? Yeah.
Can you hear me now, though?
Yes, we
Okay,
can.
perfect. So if I want to pump blood from the right atrium to the right ventricle, the pressure in the right atrium must be greater than the pressure in the right ventricle. And that's rule number 1, right? Pressure must go from high to low. Rule number 2 is that the ventricles are the diva of the show. And I'm going to be speaking about this later on, but a lot of the things that we will be focusing on is going to be centered around this left ventricle. Because ultimately speaking, the role of the heart is to pump blood to the rest of the body. And it's really the left ventricle that does that. And again, just kind of like a general theme. So rule number 1, pressure flows from high to low. Rule number 2, ventricles are the diva of the show. And now we can move on to the next part. We're going to be using a lot of terms, and I think it's very important to understand them properly. So we're going to be throwing the term diastole a lot and systole a lot. And I'm sure you guys already know this, but just for the sake of completion, diastole is the phase of the heart contractions when the ventricles fill up with blood. This is going to be the ventricle relaxation and ventricular filling. So it's when the ventricles fill up with blood. That is diastole. Systole is when ventricles push blood away, whether it's into the lungs or into the rest of the body. This is all about ventricular contraction and ventricular emptying. So that's diastole, and this is systole. Now, again, very, very simplified schematic. I have my right ventricle. This right ventricle is connected to the right atrium, and it is connected to the pulmonary artery. Let's say that the resting pressure in the pulmonary artery is 20 millimeters of mercury. And I want to pump blood from the right ventricle into the pulmonary artery, right? So I can go to the lungs and get oxygenated. In order for me to do so, again, rule number 1, the pressure must be high from one chamber to the next. So the pressure in my right ventricle should be higher than the pressure in my pulmonary artery. So blood now will flow from the right ventricle to the pulmonary artery. This is great. But we have one very important problem. The right ventricle is also connected to the right atrium. And in this case, the pressure in the right ventricle is also higher than the pressure in the right atrium. So technically speaking, the blood will flow both ways. It's going to flow forward, which we want, but it's also flowing backwards. And that's really, really bad. It doesn't make sense. We don't want blood to be flowing backwards. So to fix this problem, we have something called valves. There are 4 valves in the body, and their main job is to prevent the backwards flow of blood. So between the right atrium and the right ventricle, we have the tricuspid valve. And this tricuspid valve's job is to prevent the backwards flow of blood through the pressure gradient from right ventricle to right atrium. So it fixes our little problem that we have. Now, we have 4 valves in the body, 2 AV valves and 2 semi-lunar valves. We call them AV valves because they are found between the atrium and the ventricle. So the one between the right atrium and the right ventricle, we call it tricuspid. And you can see on the image on the right, we call it tricuspid because it has 3 cusps. It has 3 kind of like leaflets. Then we also have a mitral valve, also called the bicuspid valve, which is found between the left atrium and the left ventricle. Then we have 2 valves, which is the aortic and the pulmonary valve. They're very simple. The name tells you exactly where they are. The aortic valve is in the aorta. Its job is to prevent backwards flow of blood from the aorta back into the left ventricle. And the pulmonary valve does the same thing, but at the pulmonary artery. So again, valves' jobs are to prevent backflow of blood due to the pressure gradient. So far, does anybody have any questions?
No, everything is clear.
Perfect. Now, with this kind of like little introduction done, we can move on to the cardiac cycle. And I'm going to go through a different order from the slides because I feel this is the way how I like to do it. But this should not really matter because when you guys go over the slide contents, it's the same mechanism, it's the same concept. But for me, I want us to start this journey at the start of ventricular systole, just as the ventricle is about to contract. Now, during systole, all I want to do effectively is to push the blood from the left ventricle, all that rich oxygenated blood, all the way to the rest of the body, right? And in order for me to do so, I do it in 3 key steps. Step number 1, the AV valve will close. Step number 2, we're going to have something called isovolumetric contraction. And finally, we have the ejection phase. So again, back to a very simplified schematic. I have my left ventricle, right? Because ventricles are the diva of the show. They're the most important. So I have my left ventricle and it's connected to my aorta and it's also connected to my left atrium. Between the left atrium and the left ventricle, we have the mitral valve. And between the left ventricle and the aorta, I have my aortic valve. My job during systole is to pump all that blood from the left ventricle into the aorta. Now, in order for me to do so, I have to increase the pressure so it's higher than the pressure in the aorta. And the pressure in the aorta usually is around 120 millimeters of mercury. Now, as the ventricle just is about to contract, the pressure in the left ventricle becomes higher than the pressure in the left atrium. And that automatically will lead to the mitral valve to close. Because again, I don't want that oxygen-rich blood to go backwards and to go into the left atrium. No, I want all of it to go to the rest of the body, or as much of it. Now, one very special thing happens. The valve has closed. And whenever valves close, they are loud. They make themselves heard. Now, if I just go to like on a random street and ask people, hey, like what sound does the heart make? Everyone will say, oh, it makes lub-dub, right? Lub-dub, right? Now, turns out each one of these sounds that we hear is given a name. The first one is called an S1 or sound 1. And the second one is called an S2 or a sound 2. Now, the sound that we hear when the heart is beating is not the sound of the heart itself. It's the sound of the valves closing. So the S1 heart sound is the sound of the mitral valve and the tricuspid valve closing. And the S2 heart sound is the sound of the aortic and the pulmonary valve closing. So at the beginning of systole, the first thing that happens is the valves will close. And you are going to have the S1 heart sound. Okay, so step number 1, the AV valve will close, the mitral and tricuspid, and we're going to have the S1 heart sound. Now, the left ventricle is going to continue to contract. So it contracts, it contracts, it contracts. And as it does so, the pressure goes up and up and up. But notice one thing. The door that connects the left ventricle to the left atrium is closed. The mitral valve is closed, right? And we haven't reached a pressure high enough to open the aortic valve, right? We're still below the pressure of the aorta. So as the pressure is going up and up, there's no space for all that blood, all that volume to go. So the volume remains the same. And we call this phenomena isovolumetric. Iso is like Latin or Greek, I don't know, for same. And volumetric is to do with volume. So isovolumetric contraction. We are contracting the ventricle, but the volume remains the same. However, as this goes on, as the ventricle continues to contract and contract, eventually we reach a pressure higher than the pressure in the aorta. The aortic valve will open and all that blood will get ejected out into the aorta and into the rest of the body. And that will begin to continue until we've kind of reached the end of ventricular systole. So 3 steps, the AV valve will close, then we're going to have isovolumetric contraction, and finally we're going to have ejection. Then we move on to ventricular diastole, right? Diastole is all about relaxation. It's all about filling that ventricle with blood. All that blood that went into the lungs for oxygenation has to go back into the left ventricle so it can be pumped into the rest.
Sorry, I have a quick question.
Yeah, go for it.
How does the AV valve close? No, not the AV valve, the mitral valve.
So you mean like how does it close in terms of like physically close?
Yeah, physiological aspect.
Okay, so initially what happens is when the ventricle first begins to where is it? We go back down here. So initially the pressure is kind of like the same, right? As the left ventricle begins to contract, right, the pressure slightly becomes higher than the pressure in the left atrium. Okay, when that happens, small amounts of blood begins to flow because now the pressure of the left ventricle is higher than the pressure of the left atrium. So it's going to slightly go back, and like the anatomical way of how the heart valve is designed, when the heart begins to go backwards, it kind of like causes it to shut in, you know? It's like a parachute type of vibe. Because you have those leaflets that tied with those like choroidal tendonae. When there's backflow of blood, they physically shut down. So blood can only flow through one direction.
Thank you. That's clear.
Best way to kind of like visualize it, if you're a very, very visual person like me, is to maybe like watch a video like online, those 3D like simulated videos. You will see as the blood begins to go backwards, it kind of like forces them physically to get shut based on the orientation, you know?
Yeah, thank you.
Anytime. Okay, so now we move on to ventricular diastole, right? Now, ventricular diastole is a bit more complicated. Not really that complicated. It has one extra step, okay? Same thing as before. The first step is going to be the aortic and the pulmonary valves are going to close. Then we're going to have something called isovolumetric relaxation. Then we're going to have ventricular filling and atrial contraction. Now, again, same thing happened. The ventricle kind of contracted, squeezed as much amount of blood that it possibly can before it got fatigued and begins to relax. Now, as the left ventricle begins to relax, the pressure begins to drop, right? Pressure begins to drop. Eventually, the pressure will again drop below the pressure of the aorta. Now, the aortic pressure is higher than the left ventricle, which means we are in a situation where we may get backward flow of blood. But to stop that, the aortic valve will close. And again, whenever a valve closes, we have heart sounds. So the closure of the aortic valve will lead to the second heart sound from being formed. Once the aortic valve has closed, we continue to relax the left ventricle. So the pressure begins to drop and drop and drop. But again, the aortic valve is closed. The mitral valve is still closed. So we are again going through isovolumetric relaxation this time. So the volume remains the same, but the pressure is beginning to decrease. Eventually, however, the pressure in the left ventricle will drop below the pressure of the left atrium, which allows the mitral valve to open. And again, fluid always flows from areas of high pressure to low pressure. So the mitral valve will open and all that blood that is in the left atrium will begin to fill up the ventricles. Now, ventricular filling in general, and it kind of goes through like 3 key steps, right? You have a rapid filling stage, a slow filling stage, and then finally an atrial contraction that pushes all that little bit of blood in the left atrium into the left ventricle. And that would really make a lot of sense, those 3 stages of ventricular filling, when we actually see it in a diagram. It will make much more sense. So I'm gonna leave that for now. That is basically, in general, the cardiac cycle. At the end of diastole, we go into systole, then diastole, then systole, until like literally like GG, until you die. Any questions so far? Now we move on to the part that scared me the most from cardiac cycles, and that is something called the Wiggers diagram. It looks a bit like this, okay? And every time I see it, like internally, I die. It's like, well, I'm like now an intern, still doesn't change the fact that kills me internally. But it's actually not so bad, especially if you take it slowly and break it down into all those key steps. This is kind of like the diagram that we are going to dissect today. You can see there's a bunch of different lines, and each line means something else. At the very bottom, we have a phonocardiogram, which is basically the heart sounds. Then you have your ECG imposed on it. Then a red ventricular volume, a blue ventricular pressure graph, and a kind of grayish atrial pressure. Okay? Let's go very simple. This is the heart sounds. We know that at the beginning of systole, we had the S1 heart sound, right? The mitral valve will close. That kind of marks the beginning of systole. And we know that systole ends, okay, when the aortic valve closes. That's going to be your second heart sound, S1 and S2. So that means between S1 and S2, we have systole. And between S2 and S1, we have diastole. That's kind of like a little kind of like breakdown. Now, let's kind of like look at the ventricular volume curve, okay? The left ventricular volume curve, and see what's kind of like going on. So we have at the beginning of systole, if you notice here, the ventricular volume, okay? The left ventricular volume kind of remains the same. The graph is a straight line, doesn't really change much. So because we know that the volume hasn't changed, this kind of very much corresponds to isovolumetric contraction. We spoke about this before. The left ventricle is contracting, but both the mitral valve and the aortic valve are closed. So the volume is going to stay as a straight line. Then the aortic valve opens, and the left ventricular volume will basically begin to decrease and decrease and decrease. And we can see this on the graph. Mute for one. So that is going to be, that will continue until the very end of systole. So again, the first part of that graph immediately after S1, which marks the beginning of systole, is going to correspond to isovolumetric contraction because the line stays the same. Then the line begins to decrease, telling us that the left ventricle is losing fluid somewhere, which is the rest of the body. And this is going to be marked by this decrease in that graph. The left ventricular volume is decreasing. It was around 130, now it's nearly around 50. That will continue until the very end of systole. Then we have the second heart sound, the S2 heart sound, because the aortic valve has closed. We are moving into diastole. Now, diastole, as you can see here, there's like 3 kind of like boxes, because we said there's 3 steps to the ventricular filling. The first part is, again, isovolumetric relaxation. That graph, again, is a straight line. Nothing is happening to the volume. The ventricle is relaxing, but both the mitral valve and the aortic valve are closed. Then we move on to the ventricular filling phase, okay? First part is the rapid ventricular filling, right? That left ventricular volume curve is increasing and increasing and increasing, but then it begins to plateau and slow down, okay? And the final stage is where we have atrial contraction. That little atria kind of squeezes a bit of extra blood into the left ventricle, and you can see it as like a little bump right upwards. And again, that's the end of diastole, because then we have the S1 heart sound. Then we go into, again, systole with isovolumetric contraction, then ventricular ejection. Then we go back into diastole, and this cycle continues and continues. So now it's kind of like connecting. Let's look at the whole thing. Let's look at the whole Wiggers diagram, systole at a time, okay? We begin. The first stage of systole is isovolumetric contraction, right? We can see the S1 heart sound is there. We can see that the ventricular volume curve is a straight line, and we can see that the pressure is increasing. That's the blue line. The blue line is the ventricular pressure, and it's going up and up and up, right? Because the ventricle is contracting. So that's the isovolumetric contraction phase. Then we move on to the ejection phase, right? You can see down there that the left ventricular volume is going down. The ventricular pressure is going up, and then it plateaus and it goes down. Okay, this corresponds with the ejection phase. Why does the ventricular pressure like reaches the peak and then begins to slow down? Right, that is because as you lose that fluid, that blood, as it leaves into the aorta, right, it basically, the pressure in the chamber is going to decrease because there's less fluid. Okay, because pressure in the left ventricle is a combination of the pressure caused by the fluid itself and the pressure caused by the muscles contracting. So that's going to be at systole. Then we move on to diastole, and again, it's the same thing. You have isovolumetric relaxation. The volume is going to stay the same. It's a straight line, but the blue ventricular pressure graph line is decreasing. We know that the pressure is dropping because of isovolumetric relaxation. Then we move on to the diastolic filling phase, the initial rapid diastolic filling. Then we move on to the slow diastolic filling, and finally the atrial contraction. Okay, that's kind of like the general idea of the Wiggers diagram. I see there's a question in chat, and the question is, let's see, why don't we start from the P wave? So technically speaking, we can start from anywhere we want. I decided to start from the S1 because for me personally, I find it easier to explain, right? But we can easily start from the P wave. Now, the problem why I personally don't like starting from the P wave is it begins kind of at the beginning of the ECG cycle, yes, but also doesn't really begin at the beginning of systole or the beginning of diastole, right? It kind of begins halfway through. It begins right at the start of atrial contraction. I personally don't like to use that when teaching, but technically speaking, you can start from any point in the graph. So let's take, for example, you're starting from the P wave. We know that the P wave will basically give us the atrial contraction, right? So if we go at the P wave, we notice that immediately after that, we begin the atrial contraction phase of ventricular filling, right? Then we see that we're going to move on to the S1 heart sound, right? We're going to have the QRS complex. The QRS complex is going to be ventricular depolarization, right? It's going to cause the ventricles to contract. So it makes sense that the QRS complex is going to be at the same time as the beginning of systole. And that's exactly what you can see on this diagram. We have the QRS complex, and then immediately we enter systole. We have isovolumetric contraction, then the ejection, and etc. Does that kind of explain your question, Fad? Because it's a continuous kind of like diagram, you can start from any point you want. You can start from diastole, you can start from systole, you can start from wherever. Perfect. Before we jump into JVP waveforms, does anyone have any questions so far? Because I know me personally, Wiggers diagram is a bit confusing. It's a bit, wow, it's like spaghetti of like lines. Okay, so I'm gonna assume that's a no. I'm gonna jump into JVP waveforms. Now, one thing that we kind of skipped when we were looking at the Wiggers diagrams was that little gray curve, right? That little gray curve that was kind of like squeezed inside. That is sometimes called either the JVP waveform or the right atrial pressure curve. The reason why we call it that is because it's basically the same thing. The pressure in the jugular venous vein is considered physiologically identical to the pressure in the right atrial vein, right atrium. So we call it the right atrial pressure curve or the right jugular venous waveform or the JVP waveform. Same thing. The JVP waveform kind of has some peaks, has some descents, and has a bunch of different points. The A wave, the C wave, the X descent, the Y descent, and the V wave. And I'm going to go through each of them one by one. Let's begin with the A wave. Now, the A wave is going to be that increase in pressure in the right atrium due to atrial contraction. So A for A, okay? So obviously when the atria contract, the pressure is going to go up. That is dictated by the A wave. Then after the atria contract, the pressure begins to decrease, right? So the atria begin to relax and the pressure begins to go down. So we have the X descent. So atrial relaxation, the X descent. But before the pressure can go all the way down, something happens. The tricuspid valve closes. And when that tricuspid valve closes, right, that leads to a slight increase in pressure because the closure of the tricuspid valve itself kind of causes the blood to kind of like bounce around the right atrium, and that kind of increases the pressure just a little bit. So it's not as big as the A wave, it's smaller. That's the C wave. But then the atria continue to relax, and we have the classic X descent or atrial relaxation. Eventually, though, that the venous filling phase begins, right? All the superior vena cava and the inferior vena cava, which is draining into the right ventricle, the right atrium, is going to increase the amount of blood within the right atrium, so the pressure will increase. And that is dictated by this V wave. It goes up and up and up. Then, once the right atrium has increased to like the maximum amount of pressure, there's something called the Y descent, which is the emptying of the atrium. Now, very important, this Y descent, this emptying of the atrium is going to correspond with the rapid and the slow filling phases of ventricular filling, because afterwards, the A wave will kick in, which is atrial contraction. So that is basically the JVP waveform. And we're gonna see it right now, how it's kind of like squeezed in within the Wiggers diagram.
I have a quick question.
Go for it.
The tricuspid valve opens in the Y descent at the end of the Y descent, or at the beginning of the Y descent?
Opens or closes?
Opens.
Opens. Okay. So let's actually, good question. Let's go and see it within the Wiggers diagram and try to see if we can plot it, right? So the tricuspid valve, right, will open when we want the blood to go from the right atrium to the right ventricle, right? So that means if the tricuspid valve opens right at the beginning of filling, right, it should be at the start of the Y descent, because the Y descent begins, right, at the empty, because Y descent corresponds to the emptying of the atrium, the filling of the ventricle. So that tricuspid valve should open at the same time as the mitral valve, because one thing that is very important to note, that the heart happens in sync. Right now, we're looking at the right atrium and the right ventricle, but technically speaking, when the mitral valve closes, it's the same time as the tricuspid valve closes. And we know that the mitral valve has to open, right, at the start of ventricular filling. So to answer your question, the tricuspid valve should open around the start of the Y descent as the atrium begin to empty. You won't really see it on this Wiggers diagram because we primarily are looking at the left ventricular volume. So you won't really see it as much. That's why you don't see it labeled even here. But to kind of like also integrate this within the greater Wiggers diagram, as we can see here, we said that like for me personally, the easiest way to kind of get oriented with the JVP waveform is to look for the A wave, because the A wave is always going to be the easiest one to find because it corresponds with atrial contraction. So you just go to the last third of ventricular filling during diastole, and that's going to give you the A wave. And you can see it's right down there, corresponding with atrial systole, because it's atrial contraction. And then you will see that there is that little X descent, but it's interrupted by the C wave, which causes it to go up, and then it decreases, and then it begins to increase again, which is going to be the V wave, venous filling. Does that answer your question?
Yeah, thank you.
Anytime. And this is where you can see that here. You can also see that the C wave, which is tricuspid valve closure, is also going to be found exactly at the same time as the S1 heart sound. And it makes sense because the tricuspid valve closes at the same time as the mitral valve. And mitral valve closure and tricuspid valve closure is going to give us the S1 heart sound. So a quick, easy way to find the A wave and the C wave. And that concludes the Wiggers diagram, JVP waveforms, etc. Any questions so far? If no questions, we can move right on to cardiodynamics. So remember how early on we said that the ventricles are the diva of the show? This is exactly why we said that, is because this whole section is going to be primarily focused at the left ventricle. Now, to understand what's going on, there's going to be a bunch of different terms. It's going to be the end diastolic volume, blah, blah, blah. Let's quickly understand all the different terminology so we can understand what's going on. The first word that I want us to know is the end diastolic volume, or the EDV. Now, the end diastolic volume is basically the volume of the left ventricle at the end of diastole. So think of it as also the maximum amount of blood that is found in the left ventricle during the cardiac cycle, because it's at the end of diastole, okay? And you can see down here on the Wiggers diagram, if you see the ventricular volume curve, the highest point it reaches at the end of diastole is going to be your end diastolic volume. Then you have something called the end systolic volume, which is the left ventricular volume at the end of systole, right? And again, this will correspond to the lowest amount of blood which is found in the left ventricle, because that's at the end of systole. Most of that blood has been pumped into the aorta and the rest of the body. And again, that will correspond to the lowest point of the ventricular volume curve in the Wiggers diagram. Then we have something called stroke volume. Now, stroke volume is simply the amount of blood that has been pumped into the aorta. Now, it's basically going to be the main difference between the end diastolic and the end systolic volume. The best way to understand this is to use an example. Imagine at the end of diastole, I've loaded up my left ventricle with 100 milliliters of blood, okay? And then at the end of systole, I'm left with an end systolic volume of 30 milliliters. So I started with 100 and now I ended with 30. So the difference between them gives you the stroke volume. That means the left ventricle has pumped out 70 milliliters of blood into the aorta and into the rest of the body. That is your stroke volume. And it is very, very, very important. We also have something called the ejection fraction. Now, the ejection fraction is very similar to the stroke volume, but it's not the same. It is not the amount of blood that has been pumped, but rather it is the proportion of blood that has been pumped out. So it is going to be your stroke volume divided by your end diastolic volume. Let's say I have my left ventricle, which was initially filled up with 100 milliliters of blood. And at the end of systole, it's ended up with 30 milliliters. My stroke volume is 70 milliliters. My ejection fraction, however, is 70%. It's 70 out of 100. My heart has pumped 70% of the blood out. We never have an ejection fraction of 100%. There's always going to be some blood left over at the end of contraction. Now, this ejection fraction is very, very important because it gives us a good idea of contractility. And we're going to speak about this one later on. Now we have something called cardiac output. Now, cardiac output, honestly, is probably the most important hemodynamic, cardiodynamic measure. Because when your cardiac output goes to zero, you die. It's simple as that. Cardiac output is basically the amount of work your heart is doing. It's the amount of blood that has been pumped over a period of time. Now, that is very important. So it's the amount of blood. Sounds a lot like I'm saying the stroke volume, right? Over a period of time. So I guess heart rate. Could it be stroke volume times heart rate? That is exactly what cardiac output is. The cardiac output is the amount of blood that you are pumping over a period of time measured by your heart rate. So using that same example, I had 100 ml, I ended up with 30, my stroke volume is 70, and I have a heart rate of 70 beats per minute. That means my cardiac output is going to be 4,900 ml per minute, or 4.9 liters per minute. That's usually the cardiac output, around 5 liters. Now, this cardiac output is affected by a bunch of different variables. One of them is the heart rate, but we also have something called the preload, we have something called the afterload, we have something called the contractility. And these are very important. Now, the preload is very simple. It's the amount of blood that has been loaded into the left ventricle. And to keep it very simple, think of your preload as your end diastolic volume. Now, if I want to increase the preload, one way I can do so is by increasing the volume in the body, right? I give the patient blood. I give the patient fluids through an IV line. That will increase the amount of volume within the body. That will increase the preload. Another thing I can do to increase the preload is to slow the heart down. Now, that's kind of weird. Why would slowing the heart down increase the preload? The best way to explain this is for us to go back and look at an example, a very simple, ugly schematic, but one that does the job of a heart rate. This patient has a heart that is beating 3 times. There's 3 systole. Systole, diastole, systole, diastole. Okay? Sorry about that. Here's a different patient, okay? But this time, he has 4 contractions. If I put them side by side, I don't know if you can notice, but diastole, the duration of diastole has gotten shorter. Systole has remained the same. The duration of systole has remained the same, but the duration of diastole has gotten shorter when we increase the heart rate. That's very important because as we increase the heart rate, we only can decrease the duration of diastole. We cannot change the duration of systole. So vice versa, if I decrease the heart rate, I will increase the duration of diastole. I am giving that left ventricle more time to fill up with blood. And that's the whole concept. If I give the heart more time to fill up, I will increase my preload. And finally, another thing that we can do to increase the preload is to constrict veins. That's a bit unusual for a lot of people, but one of the functions of our veins, especially the veins in our legs, is they're very soft, they're very compliant, they are able to pool a lot of blood. If I constrict these veins, they're not pooling in my calf muscles anymore. No, now they're being pumped towards the heart. That will increase our end diastolic volume. That will increase our preload. And the opposite is true. If I lose volume, for example, if I'm bleeding out on the side of a road, I am decreasing the amount of preload within the body. I am decreasing the cardiac output. If I increase the heart rate or if I dilate those veins, all of these are going to decrease the preload. The afterload is a bit different. The afterload is all about the amount of pressure that the left ventricle has to overcome to pump blood out of the body. Now, in order for us to pump blood from the left ventricle to the aorta, I gotta do two things. Number one, I have to overcome the aortic pressure. And number two, I have to open up the aortic valve. If the aortic pressure is increased, for example, a patient has atherosclerosis or has hypertension and the pressure is higher, I have to do more work to increase the pressure of the left ventricle. Another thing that could happen is if my valves are hard to open, right? If they are calcified, if they're stuck together, I have to put in more pressure to overcome the aortic valves to allow them to open. Both of these are examples of ways that the afterload can increase. There's a question about, can you repeat constricting veins? And I'll do that now before we move on. Now, the whole concept, which is kind of, again, unusual, is that the veins are very soft, they're very compliant, they are able to stretch out very easily, which means when I'm just at home, I'm watching a movie, I'm being chilling, okay, a lot of that blood, the body doesn't need all that extra blood to go to the heart, so it begins to pool into those lower limb veins, okay? They're just there, they're pooling down, they're not doing much. If I constrict those veins, however, then those veins will push that blood out into the heart. They are not going to stay pulling down on my legs. No, they're going to reach the systemic circulation and they're going to start passing through the heart and getting pushed out. That means if I constrict those veins, I push extra blood, right, into my left ventricle. So technically speaking, my end diastolic volume will be a bit higher, right? Which means my preload is going to be higher. And that's the same reason why when you're doing exercise, when you're running, your lower limbs constricting, your calf muscles constricting, your lower limb veins constricting, with all of that will push that extra blood into your body that you can use for exercise, for movement, or whatever. Does that kind of make sense?
Can you repeat what afterload is?
Sure. So the afterload is basically the amount of pressure that the left ventricle has to reach in order to be able to pump the blood into the systemic circulation, into the aorta. Now, in order for me to do so, I got to do two things, right? I have to overcome the baseline aortic pressure, because remember, rule number one, a fluid flows from an area of high pressure to low pressure, right? So I have to reach that level of pressure before blood can even begin to flow. Then, before that, I have to open up the aortic valve, right? Imagine if I super glued the aortic valve together. No amount of pressure I reach will be able to allow that fluid to move from one compartment to the next. So the afterload tells us how much work is the left ventricle doing just to pump that blood to the rest of the circulation. So, for example, if I increase the amount of pressure in the aorta, if the patient has atherosclerosis or has calcified aorta and the pressure by baseline is higher, instead of having to reach 120, I now have to reach 130. That is more work for the heart. That is considered an increase in the afterload. The heart has to do more work to push that blood out. Alternatively, if I have very calcified valves or very sticky valves that are like not functional, they are hard to open, again, I have to do much more work to open those valves compared to very nice and smooth and flexible valves. So that's what the afterload is. It's looking at the amount of pressure the heart does to pump the blood into the aorta.
Okay, I understand. Thank you.
No problem. Good question. Finally, the last modifier of cardiac output is the contractility. Now, the contractility tells us how hard the heart squeezes when it's pumping. It's very logical, very easy to understand, right? Now, imagine two hearts, okay? Heart number one, again, end diastolic volume is 100, end systolic volume is 30, stroke volume is 70, ejection fraction 70%. And if you look at the schematic, I made the board of the heart nice and thick. Now, this is an example of a patient with a diseased heart. The end diastolic volume is the same, 100 ml. However, the end systolic volume is 60. So the stroke volume is 100 minus 60, which is 40, right? And the ejection fraction is going to be 40 over 100, right? So the ejection fraction here is going to be 60%. Sorry, 40%. And if you notice, the contractility of the diseased heart is obviously much lower than the other one. And you can tell that easily by looking at the ejection fraction. The ejection fraction is a very, very good proxy marker of the contractility of a heart. Now, another way of seeing it again is contractility is a measure of the ejection fraction. Now, one important concept is the more calcium, which is found within the cardiac muscle, the stronger the contraction. That's a very important mechanism of how everything happens later on. Now, if I want to increase the contractility, I can do so in different ways. Number one is by the sympathetic nervous system. How does the sympathetic nervous system increase contractility? We are going to go over this later on, so don't worry. But just know that the sympathetic nervous system will increase contractility. Drugs, whether it's cocaine, whether it's like actual medical drugs, all of those increase the contractility of the heart. And again, we're going to explore later on how this actually happens. So this was the cardiac output. It's modified by those 4 factors. And that kind of wraps up cardiodynamics. Once we know these terms and are comfortable with them, it will make everything else much, much easier and much simpler. Any questions so far?
May you just repeat the ejection fraction equation?
Yep, sure. So I'm going to go all the way back actually to here. So the ejection fraction is going to be your stroke volume divided by your end diastolic volume. Here I want to know how much percent of whatever fluid I had has reached the systemic circulation. So مثلا in this case, you have a patient who had 100 ml and pumped out 70, right? Which means I pumped out 70% of the blood in the left ventricle. So my ejection fraction is 70%, right? But let's say now I have a different patient, right, who maybe had a heart attack before, or has a disease of the cardiac muscle itself, right? When you calculate the ejection fraction, which is again stroke volume divided by the end diastolic volume, here they started with 100 ml, they ended with 60, stroke volume was 40, so the ejection fraction is 40%, right? And we know that the normal healthy heart in the left was 70%. So straight away, instantly, I can tell, hey, patient number 2 has decreased contractility compared to heart number 1. And I can prove this to you by telling you the ejection fraction is lower. Ejection fraction, the heart is only able to pump out 40% of what it had. That's not good, you know? That means it's not able to pump out as much as it should do. And later on in clinical cardiology, we use ejection fraction a lot to determine the ability of the heart to contract.
Yes, okay, thank you.
Is end diastolic volume always 100 ml?
Oh, no. By the way, guys, I've been making up numbers as we go along. I'm just using, look, I used 100, and I'll be honest, I'm really not good in maths, okay? I'm the kind of person who uses a calculator for 6 plus 4, okay? So I wanted 100 because it's easy to do percentages. Because 40 out of 100 is 40%. I just made it so it's easier for me because I'm very, very, very bad at maths. But the actual amounts, I personally do not know. I
Okay,
guess maybe
thanks.
just you can Google like normal and diastolic volume ranges or something. But good point. Thank you for bringing it up. These numbers are fake. Okay, so time to go through pressure volume loops. Another one of those annoying kind of like topics. Again, it looks so much worse than it really is, okay? And the best way to explain it is to go from the beginning and make our very own pressure volume loop. So here you can see on the x-axis, we have left ventricular volume, and on the y-axis, we have the left ventricular pressure, okay? We have this very weird box-shaped-like thingy. The most important thing that I want you to know is that there are 4 corners, right? There are 4 points. And we are going to go counterclockwise, okay? And we're going to go from point to point and see what's going on and try to explain how does that relate to the cardiac cycle. So let's start from these 2 bottom points, from point 1 to point 2, okay? As you can see there, the pressure is not really changing much, right? What is changing, however, is the volume. And we said previously that the lowest volume within the left ventricle is probably going to be your end systolic volume, okay? And the highest volume that you will have is probably going to be your end diastolic volume. So between point 1 and point 2, we are going from the end systolic volume, and our volume is increasing and increasing and increasing until we reach the end diastolic volume, right? So we are now in the ventricular filling phase. Because, I mean, volume is increasing in the left ventricle, right? It's getting filled up somewhere. This is ventricular filling. Then it stops, okay? From at the end of point 2, suddenly it stops, right? And we know at the end of diastole, this is when we have the closure of the mitral valves, right? And we know that the beginning of ventricular filling begins with, obviously, mitral valve opening, right? How will all that blood from the left atrium reach the left ventricle? So now we know, okay, we have MV opening at the point 1, and we have the mitral valve closing at point 2. But hey, wait a second. Mitral valve closing, don't that be making a sound? Yes, it does. And the mitral valve closure is going to be your S1 heart sound. So now we know straight away, hey, S1 heart sound, that's when systole begins. That's exactly what's going to happen. Now, from point 2 to point 3, the end diastolic volume is not the same. Sorry, it's the same. It's not changing. So the volume has remained the same. However, the pressure is increasing. And we are now at the start of systole. Does that not sound a lot like isovolumetric contraction? Because that's exactly what it is. And we know that that isovolumetric contraction will go and go and go until what? The aortic valve will open. That's exactly what happens. The aortic valve is going to open, and we go from point 2, from point 3 to point 4, and you will notice that the volume now is decreasing. We're going from the end diastolic volume to end systolic volume, which means now that we are in the ventricular ejection phase of systole. Now, remember how previously we said to calculate stroke volume, it's simply going to be the difference between the end diastolic volume and the end systolic volume. That is also denoted by the width of this pressure volume curve, okay? The stroke volume, or the width, is going to be how much blood is being pumped out into the rest of the body. And as we said, aortic valve opening is going to allow for ejection, and then at the end of systole, the aortic valve will close, which is going to be your S2 heart sound, and now we are about to enter diastole again. So again, here you can see that the volume is the same, okay? It's at the end systolic volume part of the graph. However, the pressure is decreasing, so we know we are in isovolumetric relaxation. That is going to happen until we reach a point where the mitral valve will open, and again, the cycle will continue. Mitral valve opens, left ventricle begins to fill up with blood. We are in diastole. That will continue until we reach maximum amount of blood in the left ventricle, and this will continue until like the rest of your life, basically. Any questions on the PV loop so far? Because this is just step 1. Step 2 for us is to figure out how this pressure volume loop changes when we start playing around with the preload, when we start playing around with the afterload. This is kind of like the more clinically relevant questions they love to ask. Okay. So it seems like there's no questions. We can move on. Remember how we said the cardiac output is modified by 4 factors, the heart rate, the preload, the afterload, the contractility. We can kind of ignore the heart rate because it's not really relevant to the pressure volume loop because there's no time. But the other three are relevant: the preload, the afterload, and the contractility. Now, what we're going to do is we're going to see what happens when we change these factors. So let's begin with preload, right? Preload is going to be the blood loaded into the left ventricle, right? It is basically your end diastolic volume. So using this as an example, right? Imagine I increased the preload. That means there's more blood at the end of diastole, which means the end diastolic volume is going to increase, right? So what happens is the graph is going to be like stretched out or pulled towards the right. So as you can see here, when you increase the preload, you increase the end diastolic volume. And straight away you can tell, hey, the graph looks wider. And we know that the width of the graph is the stroke volume, right? So this increased stroke volume, because it's wider, is why preload increases your cardiac output. This is why it's a good thing. And this is an example again of the exact opposite. In green, you can in gray is the control, right? In green is an example of us decreasing the preload, which means the end diastolic volume is going to shift towards the left. The graph will kind of be squished in. The stroke volume is obviously going to be less, and the opposite is true for the increasing the preload. Now, when we look at the afterload, how does that modify the pressure volume loop? Again, the afterload is the amount of pressure against the left ventricle, the amount of pressure that the left ventricle has to overcome. So using this as an example, this is our control graph. Let's say we increase the afterload, right? Let's say the patient has a disease of the aortic valve. Maybe he has calcification, or patient has high blood pressure, or like calcified aorta itself. All of these are examples of factors that will increase the afterload. What happens is the graph is going to kind of be pulled upwards. Now, the first thing you're going to notice, as we said, when we increase the afterload, the amount of pressure we have to reach before the aortic valve will open is going to be higher, right? So obviously, the amount of pressure that is reached at the end of isovolumetric contraction is going to go up. So the graph is going to be stretched upwards. But a consequence of this increase in afterload is going to be an increase in the end systolic volume. Huh? What? Kind of confusing. So let me kind of like elaborate. In each contraction, the heart has a finite amount of energy, right? If I am spending more energy in the initial isovolumetric contraction phase, if I'm spending more energy just opening up the valve, I will have less energy left over to pump blood out. If I, for example, making numbers up, I have 100 calories of energy and I spend 60 opening the valve, I only have 40 left over to pump blood out. Compared to someone who has nice, healthy valves, who's spending 40 calories opening up the valve, they have 60 calories worth of pumping blood away. So a consequence of increasing the afterload is that the amount of blood pumped out is going to be less. So your end systolic volume will increase. You have more blood left over at the end of systole. So that graph is going to get shorter. So that tells us that increasing the afterload is going to decrease the stroke volume because the graph got like narrower, right? Which means increasing the afterload will decrease the cardiac output. So that's not a good thing. So again, this is the exact same thing. We have in gray the control. We've seen what happens when we increase the afterload. Let's see what happens when we decrease the afterload. The first thing you will notice is the graph got wider. That's because the end systolic volume got lower because we have more energy left over to pump blood out. Finally, we have contractility, which is, again, a measure of the ejection fraction. And here it's the same thing. Okay, this is the baseline control graph. The first thing you'll notice is that the end systolic volume has gotten lower. Why? If my heart is more contractile, I'm able to pump more blood out. So the end systolic volume will be shifted towards the left. And because of that, you can see that the stroke volume has increased. The graph has gotten wider, which means the cardiac output has also increased. So contractility is a good thing. It allows us to have a higher cardiac output. Now, honestly, I am not sure how high yield this is for your exams. We never had this concept before. I've never seen this in any of my step 1 or any of my step 2 studying, but it's mentioned in your slides, so I just want to mention it here. This concept of contractility increasing the slope of something called an ESPVR. Now, this stands for end systolic pressure volume relationship, and it's basically a line drawn through that top left corner, right? When you notice when the contractility increases, that graph kind of shifts upwards. Just kind of like something to note in mind. The slope of the graph will increase with increased contractility, and the exact opposite is true. If the contractility decreases, that graph will go down. Now, I do want to mention something very important. The official medical cardiological term for contractility is inotropy. Okay, so something which is a positive inotrope means it has a positive effect on contractility. Something which is a negative inotrope has a negative effect on contractility. And we're gonna cover this later on, inshallah, in a bit. Any questions so far on PV loops, or any questions so far on how they change with changing those factors?
Yeah, can you go back to the slides?
Which one?
To the before this one. No, before that. Yeah, this one.
Okay.
Decreasing the afterload, is it a good thing? Because
Okay.
you will have more energy to contract.
What do you think? You tell me.
I think it's a good thing.
You are absolutely correct. It's a great thing. You know why? The graph is wider, right?
Yeah.
So you're pumping more blood out with each contraction. It's an amazing thing. So decreasing the afterload is a really, really good thing. That's why, for example, if a patient comes into you, and I know this is a bit advanced, but who cares? A patient comes to you with maybe a 70-year-old guy, very calcified aortic valve, right? You go and do for him a surgery, you fix him up, you decrease the afterload. He's going to feel much better post-op because now his heart is much more efficient. It is pumping more with each contraction, you know?
Yeah.
So you are absolutely correct. Decreasing the afterload, usually, very good thing. High afterload, not really a good thing.
Thank you.
Anytime. Starling's law, blah, blah, blah. It's really honestly very simple, okay? And by the way, we are so close to finish. We're just right around the corner. Starling's law tells you, so we know that increasing the preload will increase the cardiac output, right? Increasing the end diastolic volume, you'll have an increase in stroke volume, so cardiac output will go up. However, there's something else. So again, this is the same concept. If I have preload there and I have stroke volume up, as I increase the preload, I increase the stroke volume, everything's good. Starling's law, however, tells you increasing the preload will also increase the contractility. Okay, so it's like a double whammy. You're increasing both the preload, the cardiac output, and the contractility. But how? Starling law tells you the more you stretch the wall of the heart, the stronger the contraction. Because as you stretch the wall more, the sarcomeres get longer and they form more cross bridges. And the more cross bridges they form, the stronger a contraction they can produce. So the more end diastolic volume you put into a heart, up to a point, obviously, the more end diastolic volume you have, the stronger of a contraction you are going to get. And when we begin to combine all those factors into an equation, and for example, I have a patient and I increase the contractility or I decrease the afterload, you will notice this graph will shift upwards, right? That means for the same preload, I am now getting a higher stroke volume. I am having a higher cardiac output. That's a good thing. And like the great students mentioned early on, when he asked, hey, is decreasing the afterload a good thing? You can tell from this equation, yes, it's a great thing because you are increasing, the stroke volume. And vice versa is true. If I'm increasing the afterload or if I'm increasing the contractility, this graph is going to shift downwards. And for the same preload, for the same end diastolic volume, I am generating less of a stroke volume. That's a bad thing. I want stroke volume. So again, to summarize, if I want to increase the cardiac output, I can increase the preload, I can increase the contractility, or I can decrease the afterload. And fun fact, for anyone here who's interested in cardiology, this is practically 70% of what you're going to be doing for the rest of your life. As a cardiologist, your job is to maximize your cardiac output. So you will be playing around with these numbers. And I'll give you a nice clinical example. You're in the ER, patient comes in, had a case, patient came in, car crash, car accident. He's bleeding from his thigh. He is losing volume. his preload is decreasing. So you're like, yo, hook him up and give him some IV fluids, right? Or if you have like diarrhea or you're vomiting, you're dehydrated, first thing you do when you go to the ER, they give you IV fluids. Why? Because they want to increase your preload. You know, that is going to make you happier and healthier. Final section before we're done, and that's the role of the autonomic nervous system. Now, again, just for clarification of some terms, we have inotropy and chronotropy, okay? Inotropy refers to, as we said, contractility of the heart. And chronotropy from the Greek or Latin, I don't know, chronos, which is time. Chronotropy refers to heart rate. Now, we have, as you know, the autonomic nervous system has basically two limbs, the sympathetic nervous system and the parasympathetic nervous system, right? Sympathetic nervous system is all about fight or flight. It's all about, like, you know, being out there. Parasympathetic is more about rest and digest, relaxing, taking it easy, right? The heart is innervated by both. You have it is connected to both the sympathetic and the parasympathetic nervous system, and they both do different things, okay? Fun thought experiment. If you take a heart and you disconnect it from the autonomic nervous system, you will notice that the resting heart rate is around 100 beats per minute. Now, for the average person, the normal resting heart rate is 70. So what's going on? Why are we at baseline much lower than we should normally be at? And the answer to that question is we have constant parasympathetic outflow to the heart, which is telling you basically the parasympathetic's role is to decrease the heart rate. So we can say and conclude that the parasympathetic nervous system is an example of a negative chronotrope, okay? It will decrease the heart rate. The sympathetic nervous system, on the other hand, and I'm going to give this as an example, okay? I'm going to give you guys like an actual concrete in real life example, right? Something I think a lot of you guys are unfortunately very familiar with because you guys got the grades, I think, yesterday. I don't think from your first ever notification email from uni to the very last day of uni, you will always get the exact same feeling of dread. You'll feel your heart rate going up when you get that little ping notification of College of Medicine Assessment Committee. And first thing that's going to happen is your sympathetic system is always going to be kicked in. And we know that the sympathetic nervous system is both a positive chronotrope and a positive inotrope, which means the first thing you're going to notice is your heart rate is going to go up. So the sympathetic nervous system is going to cause an increase in your heart rate, right? Positive inotrope means the heart is going to contract even better. The contractility is going to go up. So the sympathetic nervous system will do both. And therefore, it will increase your cardiac output. It will increase your cardiac output because you are increasing the stroke volume by the positive inotropic effect. And it's also going to increase your cardiac output because you are increasing your heart rate. So how does the sympathetics increase contractility? And the short answer to this question is it's all about those beta-1 receptors. Let's take, for example, a very simple cardiac muscle cell. Let's call it Kevin, for example. Okay, Kevin wants to contract harder. He wants to give a stronger contraction. You have that little nerve, this autonomic nerve, which is producing a lot of neuroepinephrine. And suddenly it's like, you know what? It is time to activate. And it shoots neuroepinephrine towards our cell, okay, which has a beta-1 receptor. Binding up of norepinephrine to the beta-1 receptor leads to a cascade of events happening. First thing that's going to happen is you have activation of the GS protein. That will lead to an increase in the amount of cyclic AMP within the muscle cell. Cyclic AMP will lead to activation of protein kinase A. Then protein kinase A and starts going around doing a bunch of stuff, okay? To keep things simple, I'm just going to focus on the net overall effect, but it's going to increase, for example, phosphorylation and activation of L-type calcium channels. And the net effect of all of protein kinase A stuff is an increase in calcium. And we mentioned before, the more calcium within muscle cells, the stronger the contraction. This is how sympathetics lead to stronger contractility. We also mentioned early on, way early on, how some drugs can also increase contractility. Now, in the slides, I give you the example of cardiac glycosides, a type of medication that we use in patients who have heart failure to increase the contractility of those hearts, to increase their ejection fraction. Now, again, we take the same muscle cell, right? And we basically know that all these cardiac muscle cells have something called a sodium-calcium exchanger. Now, what this sodium-calcium exchanger does, for every for every 3 sodium that comes into the cell, right? Because sodium loves to go intracellularly, 1 calcium gets to leave out. Cardiac glycosides work by inhibiting not the sodium-calcium exchanger, but in fact, inhibiting something called the sodium-potassium ATPase. You guys probably know that the whole function or the whole role of those sodium ATPase is to maintain the right amount of sodium and potassium. Sodium goes in, potassium goes out. Sorry, the other way around. If the sodium-potassium ATPase is blocked, sodium is not able to leave the cell. So it begins to accumulate and accumulate and accumulate. Now you have a very high level of intracellular sodium. Sodium doesn't want to enter the cell anymore, so the sodium-calcium exchanger stops really working. Okay, there's no motivation for it to work. So that leads to an increase in the calcium also within the cell. This increase in calcium means, boom, stronger contraction, because we have, again, more calcium. Negative inotropes, again, do the exact opposite. These are different medications that we can use to decrease the contractility. For example, calcium channel blockers. They decrease the calcium influx, so you have less calcium in. Beta blockers, again, another medication that we use in the treatment of hypertension, decreases the binding of norepinephrine to the beta-1 receptor. So that means you have less GS activation, less cyclic AMP, less protein kinase A, etc. So that was sympathetics and chronotropy, right? So that was sympathetics and their role in inotropy, right? How do sympathetics increase the heart rate? This is a bit complicated, but it's all about pacemaker cells. The initiation of a depolarization begins from cells within the SA node and the AV node, which propagate that action potential, right? Sympathetics works by influencing the pacemaker cells, by opening up something called a funny current, okay? Really not a funny topic. By the way, to this day, I have no idea why it's called a funny current. I just know it does. And basically, when the sympathetics bind to the cell, they lead to an increase in CAMP. Cyclic AMP increase leads to opening of those funny currents. When these funny currents open up, they increase the rate of repolarization. So the heart repolarizes quicker and decreases the duration of that SA node and AV node. Together, the combination of these two factors lead to an increase in the heart rate. And the parasympathetics do the exact opposite. Release of acetylcholine, which is your main neurotransmitter for the parasympathetic nervous system, will decrease the funny currents, prolonging repolarization and decreasing the conduction velocity at the SA node and the AV node, so slowing down the heart rate. It also does another effect, parasympathetics. It increases potassium permeability. And when we have more potassium coming in, we are hyperpolarizing the muscle cell. This is why they have a prolonged repolarization phase. More time is needed to bring that action potential back to baseline. So the total effect of parasympathetics is, again, to decrease the heart rate, which we know because it's part of the rest and digest. Nice and slow, normal resting heart rate. Oh, that was a lot. Deep breath. We are done, by the way. Just one or two questions to kind of wrap things up. Here we have a 63-year-old patient who comes into the doctor due to chest pain when going on walks. He is found to have a problem with his aortic valve. It is calcified and hard to open. Which of the following graphs best represents this patient? Is it A, the black graph? Is it B, the blue graph? Is it C, the green graph? Or is it D, the orange graph? Orange is my favorite color, by the way. Not really, but it's one of my favorite. I'm just saying. I'm not saying it's the correct answer. Correction is actually my second favorite color. I just remembered. My favorite color is actually burgundy. Okay. I get a bunch of blues. Interesting. Blue, blue, blue. Anyone not thinking blue? Anyone anti-blue here? Man, you guys are boring. You guys are really boring. The correct answer is B. It's the blue graph. Okay. So the key word in this question, okay, is a problem with his aortic valve is calcified and hard to open, right? That tells you, hey, maybe the problem is an afterload problem. When the problem is with an increase in the afterload, right, we know that the graph is going to be shifted like upwards, right? Because we need to generate more pressure. And we also know that the end systolic volume is going to be higher because less amount of energy is used to pump blood out. So you guys are absolutely correct. It is the blue graph. Okay, and that's, again, this drawn again. Same patient. A 63-year-old patient comes into the doctor due to chest pain. He's found to have a calcified aortic valve that is difficult to open. Which of the following letter corresponds to the valve affected? A, B, C, D, or E? Man, not a single put. Ugh, whatever, bro. I'm happy. I'm happy for you guys. Like, I'm happy you guys are getting it right. But also, I'm not happy that you guys are getting it right, if that makes sense. The correct answer is yes, it is B. If the problem is at the opening of the aortic valve, we know that point A is going to be when the mitral valve will close, right? That's going to be the start of S1, because if you look at the left ventricular volume curve, that's when its isovolumetric contraction begins. So A is the S1 heart sound, A is mitral valve closing. B is going to be the aortic valve opening, okay? And C is going to be the aortic valve closing, and D is going to be the mitral valve opening. By the way, guys, a fun fact, this question that you guys just answered is from UWorld, okay? This is a step 1 question. So I'm really, really impressed, mashallah. Great stuff. And that's basically it, by the way. That's 2 lectures done. Hopefully you guys found it helpful. Does anyone have any questions, by the way, on anything? Like that, not anything in life. I'm not like a monk, but like anything in this topic. Yeah. I mean, if a question comes up later on, or if you have any questions, just I left my details here. I guess you guys have to scan the QR code. And also, what is calcification? Okay, nice. So, like the name suggests, right? I mentioned that it's basically accumulation of calcium somewhere, right? It's a problem. It's not a good thing. I mean, look, if you have calcification in your bones, that's probably a good thing, right? But if you have calcification in soft tissue, that's really not a good thing. Now, it turns out, and this is especially relevant in cardiology, as we get older and older and older, calcium begins to accumulate in places where it really shouldn't. And one of those places is the heart valves. So if you look at someone who's maybe 70 or 60 or 80, as time goes on, there's a lot of wear and tear. That aortic valve is opening since he was born. So like a few billion times, okay? Eventually, calcium can accumulate, and we call it calcified. When a valve is calcified, it's not soft. It's hard. It doesn't close properly anymore, and it becomes dysfunctional. And you guys are going to discover this topic more when we go through when you guys have the valvular disease lecture. Hopefully this helps. Also, I think foundation grades came out yesterday. My heart goes out to you guys so much. But let me just say one thing for the record, okay? Because I know not everyone probably got what they wanted, and I'm sure a lot of people failed. Do not let that negatively influence you, okay? I cannot tell you, I genuinely cannot even count how many people I know who failed foundation and are some of the smartest people from my batch, okay? To this day, me personally, have not found a block harder than foundation. The transition from high school to uni is so bad. And it's not just any uni, it's Al Faisal, okay? So do not feel demotivated about foundation. I really cannot stress. Go ask your seniors the amount of people who failed foundation and then became dean's list, if not higher, is incredible. Foundation is really not the exam that you should kind of feel bad if you did bad in, it's just more of a wake-up call. Hey, maybe the way I studied or the way how I approach exam is probably not the best anymore, but do not let that influence your psyche, okay? You guys got this, inshallah. It gets better and better from here. That's all, boys. I hope you guys have a great weekend. All the best in your upcoming, I think, CVP midterm, right? There's so much exams, bro. It's ridiculous. I feel so bad for you guys. But it gets better. Trust me. And if you have any questions, always you can hit me up in any of my links. I'm gonna send you guys this presentation of PowerPoint later on, inshallah.